Hello, and a warm welcome to those who have joined us for this evening's webinar. My name is Jim Moore, and I am a GP. I'm a GPSI and also president of the Primary Care Cardiovascular Society. This session is sponsored by both Thrombosis UK and the Primary Care Cardiovascular Society. It's a great pleasure to welcome Dr. Matt Fay, who is going to talk about the use of DOACs as the anticoagulant of choice in primary care. Matt may be known to many in the audience. He's a GP principal in Bradford and also clinical chief executive of the Affinity Care Primary Care Network. He's a highly respected primary care specialist, or indeed just simply a specialist in many areas across the cardiovascular spectrum. Many of you will know of him from his work related to AF, or perhaps in thrombosis, or possibly even in cardiovascular prevention, including hypertension. The list is long and impressive. So COVID has brought its new challenges, and Matt has risen, as expected, to that challenge, producing guidance and algorithms related to all aspects of cardiovascular disease, including heart failure. But integral to tonight's discussion is his work around atrial fibrillation and VTE. So Matt's going to talk for somewhere around 20 to 30 minutes, and then we have time for questions and discussion after. So please post your questions on the chat as we go along. Matt, over to you.
Thank you very much, Jim. It's a pleasure to be here on a bit of a rainy night in Bradford. So without further ado, I'll just move on to my declarations because we're going to bump into lots of these companies as we're discussing anticoagulation. So I work with pretty much everybody. I do bar mitzvahs and weddings and birthdays as well, if you wish. So moving on to the hub of our discussions tonight. We've been needing anticoagulants in medicine for many years. We started off with the heparins. Then, of course, we got warfarin. We got another couple of vitamin K antagonists in phenandione and esacumerol, although we don't see much of their use in England. And phenandione, although useful, pretty much disappeared about 10 years ago and became very hard for us to find. So our patients had an option of either being on injectable therapy or warfarin. And we all know the difficulties that warfarin brings with the interaction with many of the medications that we'd like to use as clinicians, but also the disruption it can be caused in people's lifestyle and the fact that what you eat affects your warfarin, how well you are affects your warfarin. And so, although a fantastic intervention, it's not without its difficulties. And then, of course, just 10 years ago, a whole load of new kids came on the block, a bit like London buses. So all of a sudden we had the 2A inhibitors, so dabigatran was the first one that we really started to notice. And then of course the 310A inhibitors came quickly in succession after that with rivaroxaban, apixaban, and then edoxaban in large stage 3 atrial fibrillation studies, as well as VTE studies. And there's more to come. This world of anticoagulation is opening up, and it's interesting that as we see new therapeutics, we're actually understanding where the magic happens when our blood goes from a liquid to a solid. And we're understanding that coagulation system better and better as we get therapies that can interact with it. But why do we need this anticoagulation? And of course, the things that immediately are thrown in there are atrial fibrillation, that fantastic 70% risk reduction in stroke risk in those people with AF, means that we always are conscious of atrial fibrillation. VTE, and I would say as a trustee of Thrombosis UK, this is generally a Cinderella subject where we're not discussing it enough, we're not understanding it enough. We're not talking to our patients about long-term prevention enough, but we know that the VTE is a big issue, particularly post-discharge, and we'll talk about some of that as the evening goes on. Mechanical heart valves still require anticoagulation in many situations, and that's still usually restricted to warfarin, but watch this space. These valves are evolving very quickly. and the anticoagulant need for that will change as well. So we need to keep an eye on that. And then, of course, we've got the thrombophilias, that desire of the blood to clot, often running through family lines. So we've got these very clear topics, but we can then divide them down even further. So in atrial fibrillation, it's not uncommon to have coronary disease as well. And if you have coronary disease, there's almost certainly a chance you're going to have an acute coronary event. So then we have the problems around requiring antiplatelet agents or two antiplatelet agents in the acute setting, which we know are ineffective in preventing AF-related stroke. So we need our anticoagulants as well. So we need to understand how we're going to use the anticoagulants with the DAPT. We also need to understand where we put our anticoagulant when we have somebody who suffers a stroke, because of course many of us are concerned about that post-hemorrhagic transformation after you suffer a stroke. And so how does the anticoagulant fit in about that, around that acute care? And then we've got the fact that because the newer anticoagulants are so easy to start and so easy to monitor, actually prescribed and initiated by primary care much more than we ever saw with warfarin. So we've got a very proactive community care that is now starting to commence anticoagulants. Moving on to VTE, again, we've got challenges. So we have the new NICE guideline in VTE published just as COVID was taking over the world, showing us that actually a DOAC would probably be our preferred intervention when it comes to acute thrombosis, both in the periphery and embolizing to the lungs. And of course, in that acute treatment, it restricts our use, so we can only use a couple of them in that situation, but far better than using low molecular weight heparins and then onto warfarin. Back in 2014, NICE did a cost appraisal of rivaroxaban in DVT and actually decided it was cheaper than conventional care. And so was trying to recommend it, but pathways have been slow to change. We have secondary prophylaxis, though those people who have unprovoked thrombosis, or we cannot understand where the thrombosis came from. We now have more studies giving us more options in how we can give ongoing care. Many patients, particularly younger patients, choosing not to have warfarin because of the faff that it involves in their lifestyle and clinic appointments, are now being offered DOACs in high and lower doses that can protect them against further events. We've had some fantastic new studies around cancer-associated thrombosis, showing us that the DOACs are a safe option here and that we can use them to prevent thrombosis in those people at end of life or with aggressive cancers. And with low molecular weight heparins all the time. And then, of course, we've got an ongoing discussion about what we should do about those people with very high risk. So as they go into hospital, or maybe even discuss COVID and where anticoagulants sit in the very high risk population. So anticoagulation has moved from a relatively simple topic into one that seems to be all encompassing, and we find it popping up more and more in our clinical lives. So let's just think about where the anticoagulants have been really cited. So in the AF guidelines, if we look back to 2014, when I had the pleasure of being a member of the committee coming up with the recommendations around anticoagulation and AF, we saw aspirin removed completely from the pathway. So if you're low risk of AF-related stroke, we're not expecting anticoagulants to be aspirin to be commenced or any intervention to be commenced. But if you carry risk, then that risk should be mitigated with the use of an anticoagulant. We look at ESC, and ESC, the European Cardiology Society, is saying that actually, if we're going to anticoagulate those CHA2DS2-VASc patients of 1 and greater, actually, our drug of choice should be a DOAC. So we've seen that move. The NICE guidance in AF is being updated this year and will be published either later this year or early next year. And we'll have to see what they have to say around anticoagulation. Have they made a move from the equity between warfarin and the DOAC? We'll have to see. The draft is currently out and attracting quite a lot of attention. Why would we want to move from the therapy that we've used for all these years, that warfarin was so effective and we all got used to warfarin? Why would we want to move? And the answer to that is improved stroke risk reduction, dramatic reduction in intracerebral hemorrhage. So the fact that we gave a therapy that always had a risk of causing bleeding in unpleasant places, and we now have the DOACs, which have been shown not only in the phase 3 studies, but also in the registries, to reduce intracerebral hemorrhage risk by 50% compared to warfarin, means it's a quite compelling story to why we might wish to use these. Reduction in major bleeding is also there, but we do have an active anticoagulant in the intestine. That is what a DOAC is, a direct oral anticoagulant. So we will see little bleeding areas within the intestine, maybe bleed some more. So we know these drugs will increase bleeding from the intestine. But when I talk to my patients, I point out that if they lose blood from the intestine, I can give them some blood back. If they lose blood into their brain, I can't give them any brain back. So we have to have sensible conversations with our patients in that respect. And then we have the new guidelines around VTE, which came out just earlier this year. And what we find there is a real move towards DOAC. And of course, when it comes to using DOAC in the acute situation to mitigate the risk of thrombosis, while we've got active clots in the peripheral circulation, we find that we've only got 2 drugs in that setting which can carry a license, because their phase 3 studies didn't have a low molecular weight bridge at the start of the intervention. We know that apixaban and rivaroxaban can be used to reduce the risk of clot. Why is this so important? Well, back in the day when we were using warfarin, and we initiated warfarin in the acute setting, we know that we actually caused harm by interfering with the careful coagulation system with acute thrombosis. We need to be careful how we treat that patient. And so we need more anticoagulant during that acute phase. So both rivaroxaban and apixaban can be used in that setting, but at higher doses than you would normally use for AF and for ongoing VTE treatment. Can it all be put in place? Can we actually bring these newer drugs to a pathway and make that work? And I'm just going to highlight a little bit of work that we did in Bradford some years ago. So we built a pathway in 2013, just as rivaroxaban was licensing, about how we would use the rivaroxaban as the first-line medication in VTE. So when you look at somebody who presents with a possible thrombosis, and remember the major signs of V are pain in the calf and a risk of VTE. You may also get swelling. You may also get pain on tight compression of the calf. But don't be fooled by somebody who carries risk factors and a painful unilateral calf that they don't have a risk of VTE. The swelling is important, but it's not the only factor. The way you're going to spot people with peripheral thrombosis is to think about it and risk assess them. And in the DVT pathway that we used in Bradford, we did that. We made sure that the Wells 2 score was used up front. If they had a Wells 2 score of 2 or greater, then we would start the anticoagulant if there was going to be a delay of 4 hours before they could get their scan. Exactly like the 2012 VTE guidance, and exactly like the 2020 guidance has said, that we need to get in there and protect our patients as quickly as possible. So where before we'd have to faff around trying to find out which chemist might have some low molecular weight heparin, or maybe sending the patient up to casualty, we now had a pathway that we could initiate in general practice to make sure we protected our patients immediately. The beauty of getting the D-dimer done right up front, and it does mean we do D-dimers on all the suspected patients, means that once the patient moves on to secondary care and has the compression ultrasound, and the radiology department accepts our direct referral, if that compression ultrasound is negative in the high-risk patient, but the D-dimer is positive, then the anticoagulant can be stopped for a week, radiology books the appointment for the follow-up scan, and the second scan is done automatically. So the patients return to general practice with either a confirmed diagnosis or the fact that the diagnosis is excluded by in line with the NICE guidance, essentially by the radiographers in our excellent department in Bradford doing that work. But then we came to a problem, which is we have a large number of patients historically on warfarin and patients on DOACs, and then we can't monitor these patients safely anymore because the whole country's gone into lockdown. So what are we going to do now? We need to monitor warfarin. Warfarin is only safe when it's monitored. It's not safe because it's a historical drug we've used for years. It's safe because it's monitored. And what happens when we can't monitor it? And we had good, the RCGP, the BHS getting together and talking about how we might actually convert people to DOACs in that setting. And their recommendation was that anybody that could be switched should be considered to be switched to a DOAC in that setting. So who were those people? And we have big studies, and these are substantial studies, looking at AF, and what we know is that in those patients who have non-valvular AF, and when I say non-valvular AF, I mean people without mechanical valves, without mechanical mitral valves, and people who have severe mitral stenosis. Now we know that the valve patients shouldn't have DOACs. Why do we say the mitral stenotics? And the answer to that is we don't have the answer. There just wasn't enough of them involved in the studies. But we have big studies showing that a bit of aortic valve disease, a bit of pulmonary or tricuspid disease, we don't need to worry about that. They can have DOACs. So we have this AF population, and then we have the VTE population. And the VTE population is even easier to discuss because on the whole, the DOACs outperformed warfarin. So we have good drugs here. There are a couple of situations where we might not want to use a DOAC in certain thrombophilias if they've been identified, but for the majority of people with a VTE event, we can use DOACs safely. So we have a recommendation from the great and the good, including the NHSE, suggesting that we're switching DOACs. The large population that need it, AF and VTE, can be evidence-based and changed. And so we just need to think about how we're going to use them. And these are the dosing regimes. Now, as far as I'm concerned, the 4 DOACs are as good as each other. You may have your local rep who will tell you that theirs is the best, but that's their job and we have to respect them doing their job, but they're pretty similar. I use all 4 of them at varying degrees, and they are all easy to use as long as you can carry this information in your head all the time. Now, because I don't do any gynecology, or some of my partners would say any normal general practice, I can carry all this information in my head. But I would suggest that in a normal head, and you're not a bit odd like me, then what the best thing to do is to choose one of these drugs, choose it as a partnership or a healthcare community, and use that drug well. Because we know if these drugs are underdosed or inappropriately used, then they do not protect as well as we may like. Interestingly, that includes low dosing. So if you think, oh, this is a little frail old lady, but the algorithm says she should be on full dose, but I'm not sure about that, I'm going to use a low dose, you are going to cause harm in bleeding and in stroke. So use the drug as per its SMPC. And these are the algorithms, and you may want to laminate the slide and have it on your wall to remind you if a patient has a particular preference. But choose your drug and use it well. So we looked at this in affinity care, and people who have seen me present before would be used to my big boxy protocols, always on one side of A4. And this is what we came up with. So if a patient requires oral anticoagulation and warfarin is mandated, as we've just said, some thrombophilias, severe mitral stenosis, mechanical heart valves, then you're going to need to use warfarin. If the patient has a burning desire that that is the drug that they want, we must respect their view. And so you may want to use warfarin because the patient really wants to use warfarin. If an anticoagulant is in place, and they don't have any reason why they can't have a DOAC, so they have none of those restrictions that I've just mentioned, then you could continue, we could discuss switching to a DOAC, and we did switched a lot of patients in early COVID. If the patient's already on a DOAC, ensure they're on the right dose. The right dose is important, so make sure they're on the right dose, and if they're not, make sure that's switched. If the patient's on warfarin and self-testing, well, they're testing themselves, and if you're supporting that, look after them. It shows the benevolence of our population that we had patients who were self-testing, who had bought their own Coagucheck for 300 quid. And when they were presented with this situation, they actually chose to stop their warfarin in favour of a DOAC and donate their machine to those patients who had to have warfarin to allow them to self-test. In many cases, the British population has really stood up during this pandemic and really shown its colours. And I am so proud of my patients who did that. If the patient's on warfarin and it's their recheck situation, so we'd normally not leave anybody more than like really 6 to 8 weeks within the warfarin system in affinity care. But if they had been very stable, if they had a personal time and therapeutic range of over 80%, we'd just move their waiting time. And so we made some adjustments to how we were monitoring warfarin during this time. If it was less than that, then we might talk about switching. If we couldn't switch, then we would talk about the fact that we needed to monitor them as appropriate. And we actually came back up with what my lead in our oral anticoagulation service called drive-by INRs, where she would literally do an INR assessment over the garden gate to give the patients the confidence that we weren't entering their houses and we weren't bringing COVID from our locality into their house. And so we had loads of quite nice pictures of people having their INR checked in the sunshine. But we had to come up with a solution. So we have these patients, many of whom were previously on warfarin, who we may now talk to about changing onto a DOAC, and we need to have a nice systematic way of looking at this. And I'm glad to say a few of us got together just before COVID, probably unfortunately down in London where I caught my COVID back in March, that we got together with MGP and discussed a guideline about the holistic management of people on anticoagulants, warfarin and DOAC, and how in general practice we can look after this, or in a well-structured anticoagulation service, they would be looking after patients who are taking DOACs or warfarin. But remembering that this is not a drug, this is a person taking a medication, and we have to focus on the person, we have to help them with their view of the medication, we have to support them when they are starting the drug, we have to support them when they're in maintenance. We know that there are times when that person may need to discontinue their anticoagulation to allow them to have a surgical procedure, or because they're having dental work, or for some reason it needs to be discontinued. And so we also need to support our patients restarting. The patient may have stopped for their own personal beliefs. They may have changed their view as to whether or not they want to have an anticoagulant. And we need to understand why they felt that and discuss it with them and ensure that's always an informed decision and restart as appropriate. But we also have to have systems in our practices in our healthcare community about how those people who are approaching the end of life, where their metabolism becomes quite unstable, as to when an anticoagulant may be discontinued. I don't think anybody would want to have a patient who has their anticoagulant discontinued and doesn't end their life dying slowly of their cancer, but ends their life dying slowly of their cancer with their devastating stroke. So it always has to be in this conversation with the patient. We must support our patients when it comes to these kind of decisions. And the MGP have got this fantastic pathway developed on their website. So I encourage people to go there. And with that, Jim, I think that's enough of me talking. So I'll stop there and hand back over to you.
Matt, that was a fantastic tour of the use of DOACs both in AF and VTE and throws up so many different points that we could talk about. I think one of the things I'd like to talk about first of all is just this definition, and you made that in your talk about non-valvular atrial fibrillation, or what is valvular atrial fibrillation, and it's just a point of clarity. Some people say, well, how will I know that this patient has so-called, they don't have non-valvular atrial fibrillation because they've had, they've got a new heart valve? Well, the answer to that's fairly simple. The mechanical heart valve will be diagnosed by simply putting the stethoscope on the chest, if you don't have access to that sort of information. And it is quite important. In fact, you don't need to put the stethoscope on the chest. If you go close to them, you will often hear the valve just ticking away. But it is important, because the alternative type of valve replacement is a biological valve. And these are patients who, if they develop atrial fibrillation or have atrial fibrillation in the longer term, they are eligible for using DOACs. So that's an important point. The point about severe mitral stenosis, well, that's not something that we see very, very often in primary care. It's something, unless you spent a lot of years auscultating hearts, it's very unlikely you'll actually pick it up. And if you do, and you're one of those sad individuals like me, you are really kind of, happy's not the right word, but it makes your day. You've heard that very rare murmur of mitral stenosis. But we know with mitral stenosis, as you said, Matt, they weren't included in the trials, but we also know their risk of stroke is huge, because with severe mitral stenosis, the left atrium is ballooned and dilated, and so the blood flow is slow, and the environment for making clot is much, much greater.
Yeah, I mean, there's just the increase 15-fold. So AF increases your 5-fold, but with severe mitral valve disease, that's 17-fold. And I think that's hard to push through any ethics committee before you prove that it works in basic AF.
No, absolutely, absolutely. So, and you talked about giving patients choice around anticoagulation. So, the warfarin versus DOAC, and in keeping with nice guidance, Matt, I still offer that choice to patients, even though, I talk about the reduction in intracranial hemorrhage, et cetera, and by and large, all but a very small percentage of my patients now opt for warfarin. And the ones that do tend to do so because either their spouse actually comes and is on warfarin for another reason, has their INRs checked, and they really like the nurse that runs their INR clinic, so they want to do the same as their spouse. But otherwise, very few patients opt for that. One of the things when we did this bit of work down in the southern part of England called "Don't Wait to Anticoagulate," and we looked at our high-risk patients and anticoagulation. One of the things we discovered when we looked at warfarin was the number of patients who were not having regular time in the therapeutic range measured. And so in some instances where I am, there was point of care testing and that information was available, but the local laboratory was not producing actually information around time in the therapeutic range. And it's absolutely vital that if the decision is made to carry on with warfarin, that you have that information. It's interesting that in the NICE guidance and the quoted figure around an acceptable TTR is 65%. But I mean, when you reflect on that, would you be happy with a time in the therapeutic range that's only 2/3? I think, like you and in your algorithm, Matt, 80%, 90% would be what I'd be aiming for if I had to.
Absolutely. I mean, we've got a fantastic team in Affinity Care, and most anticoagulation services have these incredibly dedicated staff, making sure we get the time therapeutic range up. If you look at the Eileen Heilich work from Canada, what you find is that, once you get below 70%, things do start dropping off quite quickly. And then, of course, we have the study that showed really, if you're below 80% time therapeutic range, that you actually see an increase in dementia compared to people with more aggressive control. And I think we have to take that into account and inform our patients about that risk. Where with the DOACs, because they're in therapeutic range. They are. And we've just had some fantastic data released, which has alleviated those people who were scared, who had fears about body mass, because now we've got data to suggest at the extremes of body mass they seem to work as they did, and that was fantastic, particularly since it came in looking at edoxaban, DVT studies, when that's one of the drugs where in its SMPC it said be careful about excessive body mass. And yet they've been fantastic in in orchestrating the evidence that actually that doesn't matter as much as we previously were concerned. And we should have, we should of course encourage our patients to try and exist in a good body form. But if we can't do that, we can still use the DOACs.
So that's a really important point, because when it comes to your decision making around dosing, body weight's an important parameter, and actual body weight was what was used in the four kind of seminal RCTs, and the guidance does say at the current time, because it's not been changed as yet, Matt, that you should use these drugs in a weight range between 50 kilograms and 120 kilograms. Although I know that certainly for one of the DOACs there was, and you've actually, I've had some further education tonight, but one of the DOACs you could use up to, there was some evidence, I'm not sure if it was published, but evidence that you could use it up to 150 kilograms. But the concern for me is those patients who are under 50 kilograms. And up till now, I've been kind of involving my hematologist and asking them whether I should be measuring their anti-factor 10A activity, both in trough and peak. But I think you're telling me something different now.
I'll send you the paper, Jim. It was published a couple of weeks ago.
Right.
I mean, it's sub-analysis, it's got all the caveats that we carry with that. But when we've looked at work, from the Dresden registry and such like, we've not seen an issue. And it's nice to get further data to support that.
And that was taking body weight. So, how far did it expand that range, or was it just across the whole population?
Oh, now you're pushing the upper limit was quite large.
Yeah.
Can I interject?
Yes.
Sorry.
Yeah, Joe.
Yeah, early this afternoon, we held another session with Beverly Hunt and Andy Cohen, who has done a lot of work about DOACs in what the title was in obesity, but it was also in high body weight, because obviously it depends what, you could be a bodybuilder and be of a good weight, but also a very fit person. And that session will be available tomorrow, but it's really interesting to see the evidence, and it goes up beyond 150 and down to 35 kilograms for the lower weight as well. But I would suggest people watch that. It's really interesting seeing all the clinical evidence behind it as well.
Right, and was that, sorry Joe, I missed that, was that
And the other thing that, of course, Jim,
I was going to say, was that for particular DOAC, Joe, or was that across
DOAC use? It was across the DOAC use.
DOAC use. Okay, that's very helpful. Sorry, Matt.
And Jim, while we're talking about weight, of course, we need to also just remind people that when we're talking about renal function, we're talking about creatinine clearance and not EGFR. Yeah. So the two big clinical systems in primary care can both calculate the creatinine clearance. But again, it's one of those things where, as Jim says, depends if you're talking about ideal body weight or actual body weight and how you use that. And so an important point within a practice or within a healthcare community is you all agree on what you're doing when you're calculating the Cockcroft-Gault equation, and make sure everybody sticks to the same thing, because it could be that the hospital uses one setting and shifts somebody's dose down, and then they come back into the community and we use just a different algorithm and we dose them back up again. So it's important to remember that when we talk about the Cockcroft-Gault, that some will use an ideal body weight, as Jim stated, of course. You said, Jim, the studies used actual body weight, so it's important that we all keep consistent. It's not necessarily with the studies, definitely with each other.
I must say so that's what we, and we are consistent not only in the practice, but certainly across the area that I work with other practices about using, because our pharmacists have a big input into what's going on with management of DOACs. So we are using actual body weight as opposed to ideal. But the other problem with the common systems, Matt, and you may have come across this in any case with System 1 and with EMIS, that at certain BMIs, the calculator decides to default to a different way of measuring things. And again, that's raised questions about accuracy and measurement of estimated creatinine clearance. So what we advise primary care healthcare professionals to do is, if you take the calculation usually comes up when you go to any of these systems, EMIS or System 1, you get a calculation in clinical tools, renal calculation, and it presents a series of data around age and gender and height, etc., etc. If you simply take the height out of there, the calculator can't calculate BMI, so it can't default. So that's what we tell GPs to do. Simply take the height out of that calculation. It'll make no difference to the actual estimated creatinine clearance, but what it will do is not allow the algorithm, software algorithm, to default based on BMI, and that's what we've been using. So
I noticed in the questions, Jim, that we're honoured to have Sue Bacon in our audience, and she uses actual body weight, and if Sue does it, then it must be true. So we're all obviously correct.
I was going to say, I'm along with you on that, Sue. Yeah. So I'm sometimes asked the question, Matt, so if you think about your population of new diagnosis of atrial fibrillation and anticoagulation, how quickly do you expect to anticoagulate that individual that's sitting in front of you? What proportion of your patients do you have anticoagulated by the time by the end of that consultation, etc.?
So, if you'll bear me a short anecdote, yes. I was a few Christmases ago in that hectic week between Christmas and New Year. I was the on-call doctor, and I got called out to a patient in Queensbury. They're stoical people in Queensbury, and you have to be to live on the top of that hill. And I was called out by the daughter who was a lawyer on the M1 going home back to the nice southern counties, that her mum needed to be seen. So I went round to see her mum, who was petrified that the GP had been called out, as we see so often in our village. And while she was chatting to me about feeling slightly off colour, I could see her AF in a carotid beating away irregularly in the carotid. So I reveal my cardia and do my one lead ECG there, and then and show it to clearly be atrial fibrillation. There's no P waves to be seen. And I talked to her about stroke risk assessment and the fact we'd be going on to do an echocardiogram. But I'd leave her a couple of days to have a think about it, and we'll get the nurses to come out and get some bloods updated and see how things should go. That was on the Monday, and she had her stroke on the Wednesday when the nurses were going out on the Friday. Yeah. So I leave the house. If the patient wants to be anticoagulated, I will leave. The patient will leave my presence anticoagulated. And what I do in those patients where I have not got an up-to-date renal function, and for me up-to-date is within 3 months, then I would use the lower renal dosage of either edoxaban or rivaroxaban in that setting, because I can protect them a bit, and by the time I get the electrolytes, I can boost that dose up to the full dose if that's what's required. The chances that I would have a renal crash lander who I couldn't use a DOAC in is really unlikely, because they are usually really ill. So for me, the patient is, if the patient wants to be protected against their AF-related stroke, I will protect them against their AF-related stroke then and then.
And I think, I mean, Matt, it's interesting, although there's no official guidance on that, that's exactly what I do. If I don't have any renal function within 3 months, but say I can look over their renal function, say over the past year, and if I see 2 or 3 results that are stable, yep, and the patient's actually hemodynamically stable, I will actually give them the relevant dose at that point, but checking their getting a serum creatinine there and then before the patient actually leaves. And other than a Friday, I'll have that result, or would have, or one of my partners would have that result the other day. So we reckon when we discuss this in the practice that somewhere around 90% of our patients will leave with an arranged prescription for an anticoagulant, a DOAC basically. Having presented with AF, having had the diagnosis, of course, made on the basis of a lead 1 ECG or a 12-lead ECG, where where you can look, there's someone who can look and interpret that and confidently say that's atrial fibrillation.
So Jim, I'm going to bend the conversation a little bit back to my other passion of thrombosis, because we have an interesting question about why do we need a second D-dimer on patients who have got a negative scan. So remember, when we're thinking about our DVT pathway, remember we're not doing a DVT pathway, we're doing a pulmonary embolism exclusion pathway. So we're risk assessing our patients to see if they are at risk of a PE because that clot has managed to progress above the knee into the femoral vein. And one of our problems is that when we do our pathway, we do that initial scan, it could be that that patient is a high-risk patient and we've just not had enough time for that clot to propagate. And so we need to give it time. So when you look at how we exclude high-risk thrombosis, that's thrombosis that's progressed beyond the knee, then we can do our compression scan. If it's negative, that could be because we've not had progression, or it could be the fact that the clot's never going to do that and the clot isn't that active. And so we do a D-dimer, and we do that D-dimer in somebody who was high risk, so Wells 2 or more. Negative scan, we do a D-dimer because we know on that second scan 1 in 10 of the previously negative scans will be positive. Yeah. So it's really important that when you're looking at these pathways that you do have that second scan. Now, some people say, well, the easy way to do that would be to scan the whole leg and see if the clot's in the calf anyway. Calf scanning is difficult. And if you have a little bit of fat around that, if you have a bit of edema around that, that can be difficult. But not only that, we have no evidence that anticoagulating calf vein thrombosis makes a big difference to prognosis. So we may be putting somebody on a high-risk anticoagulant when actually their prognosis is now more affected by their treatment than their thrombosis. So the second that D-dimer to determine who is still considered at risk is important, and you've got to have 2 negatives to get out of the pathway. You either have a negative risk score, a negative D-dimer, and a negative scan. But if you've got a collection of a positive risk and a negative scan, you need another negative to get out of the pathway, and that's either a negative D-dimer, so you don't require a second scan, or a second scan, which is negative. So we've got to assess the risk. And it's important to make sure our pathways that are commissioned for us have both scans.
That's really important, Martin. It was certainly when the updated guidance was produced, and I must say, the fact that, the NICE VTE guidance coincided with COVID created problems. It simply, and I think you said it earlier on, it came under the radar. I mean, for many, it wasn't, and in fact, it's where I am, we still haven't updated the pathway. We are still doing single whole leg scans. And of course, it's described within NICE about having access within 4 hours or 24 hours to these investigations. Where I am, that isn't at the present time a practical solution.
Again, I'm going to commend Bradford Hospitals. Fantastic support when we put the pathway together. The radiologists, the hematologists, the general practitioners all play together to make this a nice, compliant, and therefore safe for our patients pathway. And Sam Aykroyd and Mark Conn really made things happen in Bradford, and we should be very proud of our team.
There is one of our listeners, our attendees, has asked, are there any DVT pathways that can please be shared following NICE? Well, of course, you've just presented an updated pathway, and you are the man with the up-to-date COVID algorithms, Matt.
Yes. So my email's on the slide. More than happy for people to email me. I'll send out. We made a package of information, so not just the pathway itself, but the educational materials that we gave to the GPs, the patients, how the radiology department supported us so admirably. Yeah, it was all put together in a little zip file. I can send all that out to people.
I mean that would be very, very, very helpful. We've got a question. We've got a comment here from Sue, who says, surely the dose, and I think we're talking about DOAC and atrial fibrillation, surely the dose would depend on the patient. And if no history of renal problems, would one not assume that it is okay, stroke versus risk of bleeding? As I've heard of more strokes due to under anticoagulation than bleeding due to over anticoagulation. See Xanthus. That's a Rivaroxaban real world study.
So Sue, I can feel the slap from here. And the lady in question was 86. So less confidence. And she did actually go on to low dose, because I'm glad to say it was a non-disabling stroke. And she did go on to the lower renal dose. I think that the point is well made. But I think if you've got frailer patients at the extreme of age, because of course as any GP in the audience will, I'm sure, immediately be thinking, is that week before Christmas, in between Christmas and New Year, that we try and strip the staff down a bit, and I still did a home visit. I rarely am seen on the streets of Queensbury, but it was a relatively frail lady in her own home, so I would weigh the situation, but I would never leave somebody unprotected again if they wanted their anticoagulant.
So Sue's also asking on the point of VTE, so no anticoagulation until the patient has 2 negative scans.
Oh no, so that's what I said.
That's not what the algorithm
anticoagulate. So in a fantastic service where you come in and you are assessed, and we know we've got these fantastic services out there in the country, you're assessed and your scan is within 4 hours. So there's no delay from you presenting to getting that scan. Then you wouldn't be anticoagulated. If that was a positive Wells, negative first scan, positive D-dimer, then you would still not be anticoagulated until the second scan. The problem about anticoagulating between the 2 scans, of course, is we're stopping progression. So we're making it so that the first scan is negative. We've anticoagulated, so we're stopping any chance that the clot may actually propagate, even though it can. It's not doing that because we're anticoagulating. Then we repeat the scan and we don't see the clot. Then we stop the anticoagulant, but not only do we stop the anticoagulant, we discharge the patient, and they could then go on to have harm. So the reason we don't have an anticoagulant between the 2 scans is because we have to let the clot show us its nature and show us what it's going to do.
Can I just reassure those attendees that this session is being recorded and will be available afterwards to download and view at your leisure. Matt, you said something that we've talked about before, and it'd be useful just to explore that a bit more about pain as a feature of deep vein thrombosis.
Yeah, so I think one of our problems is that we've kind of had it drummed into us that somebody with a DVT will have edema. And will have venous pooling and a swollen leg, or even to the level that you can see the peripheral veins dilating as the blood's just desperately trying to find a way home, and it can't get through those deep veins. But actually, there's several symptoms which are common for DVT, and pain is present in about 50-60% of all patients. So you have unilateral calf pain, and if you see somebody with unilateral calf pain, then you should really, I would argue, do a Wells score, because that will make you think of thrombosis. Yeah, and they've had the protracted period of immobility, whether that's a long haul flight or being wedged on a coach for 12 hours as you go from your homeland to the West Country. Yeah, but you see a potential risk factor, and then you should think of thrombosis. If the calves are the same size, then that means you don't score that point in the Wells score. But as you can see, there's lots of other points there that you will score. And so if you think of thrombosis, because you see the risk, so when you're talking to somebody about their pain in their calf, you should add in, have you been to hospital recently? Is there a history of thrombosis in your family? Are they a smoker? You know, you should be building the risk table in your head. And if you get a well score of 2, do a D-dimer. You know, if you don't think about it, the big problem with us clinicians about missing thrombosis is not the fact that we're not good at it, it's the fact that we didn't think of it. Because once we think about it, I think we do it quite well. It's just that we don't think about it. So, yeah, really important.
And a similar anecdote, Matt, on the same point. Young woman presenting with no other risk factors, but with pain in the calf, unexplained, did a wells, decided I would measure the D-dimer. D-dimer was up. She had a thrombosis. And, you know, once you have one case like that, it doesn't leave you. So you know, it raises your awareness, doesn't it?
Yeah. Another question there from Helen about how would we manage people with extensive superficial thrombosis. So for those of us to get really confused, what a lot of time the haematologists abbreviate to an SVT. They're often not talking about tachycardias. They're talking about superficial venous thrombosis. And absolutely, an extensive length, so greater than 12 centimeters, particularly if it's up near the femoral, then I would be discussing that case with a local haematologist. We don't have a pathway in Bradford for SVT, but I would discuss it with the haematologist because I know in many cases they would want to consider anticoagulation, because when you've got extensive SVT, as I say, thrombosis in this case, rather than tachycardia, then often there is associated deep vein thrombosis. And so it's important that you do discuss that. There are little segments that we might have previously given hydroid treatment for, you know, a couple of centimeters, less significant, probably local trauma. But when you've got an extensive area of SVT, then it's important that you consider the fact that they could have deep vein thrombosis, and you will find that a keen haematologist would be recommending a period of anticoagulation, usually with a DOAC these days. But you know, we shouldn't just be like giving them the non-steroidal cream and telling them to rub it on to alleviate pain symptoms. We do need to consider there may be associated deep vein thrombosis or propagation to the deep veins.
Yeah, presumably, Matt, there is a value in doing D-dimer or scans there, particularly if you've got an extensive superficial thrombophlebitis. That is likely to be there for an extended period of time as it settles down. So is there value in doing these investigations, or would you just, on having discussed it with a haematologist?
As I say, if you've got an extensive segment, particularly up on the top of the thigh, then I think you'd find your local haematologist will want to scan, will want to consider a D-dimer. Will a D-dimer make you change your mind? I would have a chat to your local haematologist, because the D-dimer is going to be elevated with that much thrombosis going on. Remember that the vein isn't overly inflamed, Jim. It's the clot. So we do, it's thrombosis, not a phlebitis.
Okay. Another learning point. Thank you. Thank you very much. Thanks very much, Matt.
But one of these days, Joe, you're going to start questioning me about heart failure, and I'll be in pieces.
No, indeed. So I'm just looking to see if we got any other questions that we've missed. No, I think you've probably answered all those. Can I just coming back to atrial fibrillation? One of the interesting points that we've kind of discussed. I'm coming back to cardiac problems, Matt, of course. One of the interesting things I've had some recent discussions around is what you would do in a patient with a history of stroke who is taking clopidogrel. and that patient develops atrial fibrillation. And I've had different views from different specialists about this. What do you do about the medication? So obviously, they're going to need anticoagulated because of their atrial fibrillation, unless there's some good reason that you've outlined not to do that. But the question is, what do you do about the antiplatelet? And I've had one very well-known stroke physician who would say, whatever the circumstance, I would stop the antiplatelet and just give the DOAC alone. But have had other and equally impressive stroke physician who said, well, I would want to look more closely at the investigations, look at the what's happened, or what information we have around the carotids before I necessarily stop the antiplatelet. And potentially continue them both with the increased risk of bleeding, etc. What do you do in that situation?
Well, I think that the problem that we have is a relative paucity with the stroke situation, but we have one vascular tree. And so what do we do if you have chronic coronary disease and have AF? So you've not had an event within the previous 12 months, and now you're in AF, and we would stop the antiplatelet agents and we would continue on with our oral anticoagulant, whether it be warfarin or whether it be a DOAC. If we have carotid disease, and it's stable carotid disease, so they've not had their stroke event within the previous 12 months, then I think we can easily fall back onto that evidence base that we have from the coronaries to say that we've got one arterial tree and we can treat it the same. I think the problem comes in the fact that, of course, we don't often have the acute occlusion that we have with a coronary. We don't have that acute occlusion in the carotid being the source of stroke. It's usually microemboli of debris going higher up, and it would seem logical that an anticoagulant would probably make a difference to that microemboli as well. Quite often, of course, with the patients with clopidogrel or their antiplatelet post-stroke, the carotids don't look that bad. And it could be that, of course, their stroke was because they had paroxysmal AF and we're yet to find it. And so the reason they've gone on to have further events is because we were treating the wrong illness.
So I think the summary to that is, in your opinion, or what you in that sort of case, you would stop the antiplatelet and carry on with the anticoagulant. And I assume that extends to peripheral arterial disease. I did ask, I certainly the conversations I've had with vascular. I have one Oxford trialist who is also a local vascular surgeon, who told me quite categorically that he would be confident about stopping the antiplatelets.
And I would agree completely.
Yeah,
absolutely.
Do you have any, there's a question coming, do you have any advice on dosing with DOACs? I think that will be, if the creatinine clearance is greater than 95 mils per minute, these are the hyperfiltration. The only drug that makes a comment about that is edoxaban. Again, it does, indeed. And so the others don't talk about hyperfiltrators. And to be honest, the majority of our patients wouldn't get into that group anyway. The nature of AF being an age-related illness, you may see it a little bit more with VT, but less with the older AF population. So I would always use it as per the SMPC. And if they say we can, we can. Okay, again, I agree entirely. I mean, you do see this, when you look at the seminal trials, you do see the same sort of effect as you see in Engage with edoxaban, but as you say, it's not within the SMPC in the same way as it's stated within with edoxaban. Any other?
So we're going to have a very, very brief comment about Orbit.
Carry on.
Our view about Orbit. And my view is that I think that you need to use a bleeding risk tool, whether you choose to use Orbit or Hasbled. Remember that bleeding risk alone shouldn't preclude somebody from having an oral anticoagulant. It's the patient who takes the risk of treatment through bleeding, it's the patient who takes the risk of no treatment through stroke, and it has to be a patient-orientated decision, because it's them who carry the risk, not you. Orbit, I think, is useful because it's a little bit more focused on the things I can change, and I'm interested in the things I can change. Has bled, you've got to remember which factors you can change and which ones you can't, and so it's it's a little bit more convoluted. But the best way to assess bleeding risk is, what can I do if the patient wants this drug, and often the patient wants this drug? How can I make that drug as safe as possible for the patient, because they don't want the risk of stroke, and I have to try and minimize the risk of bleeding as much as possible, but the risk of bleeding is always less than the risk of stroke, and it's just about making the drug safe. So you use whichever bleeding risk score you wish. I know that the new AF guideline is talking about Orbit, but the major thing is that you do a bleeding risk assessment and you minimize the patient's risk if they want to minimize their risk of stroke, and it should always revolve around the patient. It should be an orbit around the patient, I would say. That's where I'd use Orbit. When it comes
to be honest, Matt, I don't use a bleeding score. I just have familiarized myself with those modifiable risk factors that are important to discuss. And as you rightly point out at the end, that there is really no situation, and certainly according to HASBLED, there's no HASBLED score at which I would not consider anticoagulation. The people who really challenge me when it comes to anticoagulation are the patients with the chronic or microcytic anemias, or the previous history of bleeds, and those are the ones which I find more of a challenge. When it comes back, just a few important points, because we're at that point where we should be winding up. Again, choice of DOACs, completely agree. For me, it's what's simplest for the patient to use, having had an informed discussion, and what's simplest for the physician to use, and agree entirely. Choose one DOAC you're familiar with. It's fine for you and I to look at that expanded group and perhaps have knowledge around the nuances, but for 99% of what you need to do around anticoagulation, you simply need to become familiar with one DOAC, in my humble opinion.
Great.
Matt, I think it's time to draw this to a close. I could talk. I've got a whole list of things I've written down I could talk on about, but I think it's probably time, as I say, to draw things to a close. Superb presentation. It's been a great opportunity to discuss the work you've been doing, and thanks for sharing your expertise and your experience with us this evening. As I said earlier, there is a recording of this webinar available for people to download after we finish. So thank you, the audience, for joining us this evening.